I can at least do a couple here.
Yeah, just while I have a connection.
Okay, do you see a CT scan?
Yeah.
Good.
Okay. 74-year-old man. This is a patient at the VA, and this was a runoff or some sort of CTA, the lower abdomen, pelvis, and lower extremities. I don't know what the symptoms were, but they noted in his left lower lobe, this is as high as we go, that there's cut off of the bronchus and a bunch of mucus, pus, something filled bronchi that you can see dilated here and radiating out into the left lower lobe. And so this was as far proximal as they imaged. And maybe here we can see that there's not really a discrete mass. There certainly could be a small mass obstructing this. But they, based on that, they were worried about cancer. And I'll show you, going back to a CT he had in 2015, that there certainly wasn't a nodule back then or anything in the bronchus. But he did have another clue, which was on the right side. He had some little centrilobular nodules and a little nodular consolidation in the other side. And he has a big hiatal hernia. So when they got the follow-up chest CT, my colleague Kim saw this. And unfortunately, we did this as a low dose, so you can't really see that much. But everybody was thinking cancer, but she correctly or astutely suggested that maybe this was just something aspirated, since he had the prior stuff in the right lower lobe, didn't really see a discrete mass, and there was that little lower attenuation focus on the abdomen pelvis CT. And so the pulmonologist just took him to bronch a couple days ago, and sure enough, there was no mass, but there was some sort of leguminous material. And he said it was more green. It's just the picture makes it look a little bit more yellow, but some sort of bean or something in there. And once they took it out, there was a bunch of food beyond it. And he just said he was impressed at how erythematous and thickened the airway was, and that all of this white stuff was basically just pus, that all of these airways, they just kept aspirating more and more and more pus out of these airways. So I know Jeff usually is the best at getting the bronch pictures, but I wanted to show this just because I thought it was a nice correlate here. And so I think that probably on this abdomen pelvis CT, that this is the object right here with that more fat attenuation like you often see with beans or vegetable food stuff, whatever. But no mass, just another foreign body obstructing in somebody that was aspirating.
Yeah, it looks like a lentil.
Yeah.
A true lentil aspirate.
Yeah, you've had a few of those cases of lentils, right?
Yeah, and corn and a pea and a peanut.
So let's see, did David hop on yet? Yeah, he did. So this is my bizarre infection case for the year. And this is another, just kind of a theme of patients that look like they could have cancer but don't. This is a 54-year-old man who came in, and on the radiograph you can see there's volume loss on the right side. There's big, what looks like an infrahilar mass, and probably has a small effusion on that side as well. You can see in small left effusion. And so he had a few weeks of worsening symptoms, cough, night sweats, B symptoms. And this is another one. This was done at an outside hospital and transferred in with a presumptive diagnosis of cancer. That this was all called mass. And I don't disagree with that in the sense it looks like it could be, except some of the features we often see when you have a big mass are displacement of vessels, like the mass taking up space, pushing things out of the way. And certainly things are attenuated here. There's a small effusion. I think one of the things that struck me, though, was you see here his trachea, how there's so much thickening of the wall of the trachea, because it's the cartilage. So the trachea is just really edematous, and all of this lymph adenopathy is it's just a conglomerate. It's not really discrete lymph nodes. And so, I raised the possibility maybe it was lymphoma, maybe it was something like tuberculosis. He underwent a TB workup, which was negative. He also had some weird liver lesions as well. But they were worried about lymphoma or leukemia because he came in with low counts. But eventually they diagnosed him with something I was not familiar with, which is Talaromyces or Talaromyces marneffii, which is a fungus, formerly a penicillium species. And I don't know if you guys have seen this before. This is an Asian man, and it's endemic in Asia, and is typically seen in patients that are immunosuppressed with HIV. It's the third or the fourth most common opportunistic infection in patients in Asia. Now, he actually was subsequently diagnosed with myelodysplastic syndrome, which is why his counts were low. But I don't know. I haven't seen this infection before, but it's a disseminated fungus seen in immunocompromised patients. And it's interesting too that the first patient was an American missionary who was immunocompromised with Hodgkin's disease that had been to Southeast Asia. So, have you guys seen this before?
Never
heard of it?
No. But you're right, it is endemic in Southeast Asia where it's considered opportunistic everywhere else.
Yeah, so presumably he acquired it there like other fungal infections, and now he's immunocompromised. And he ended up having disseminated infection basically everywhere. He had a bone marrow biopsy, he had bone marrow involvement from the infection as well, and lymph nodes. I guess it was growing out of the pleural fluid as well. But I've had questions because the pulmonologist was like, "How do you know this isn't cancer?" And I think other than the things I said, like just the involvement of the airway and just how it looked like it was more inflamed, I don't really have any good explanation. But I think it's just another reminder that not everything is cancer, even though we do see a lot of cancer. So,
Travis, was this guy Asian? Did he have an Asian
he
source?
was, yeah. Yeah, he was Asian. He was from China. There's some mention of how he had some sort of questionable history of thymic neoplasm or thyroid cancer in China. But yeah, he was Asian, and now he's here, and now he's immunocompromised. So I don't know, David. It's something you might also see on the West Coast too.
Right. I'll keep my eyes peeled.
All right. Well, Jeff, I'll stop there with those two because we've got other people, and I can always show more later. But.
Okay. Thanks. All righty. Who's up next?
Can I go? I might have to cover an MR.
Yeah, of course. Thanks, Seth.
Let's see if this works. Okay. Everyone should see a MR. Let me just try to make this full screen. So this is interesting because it was a case where a patient had let me try to move this darn thing. Okay, so a patient had a coarc that was not well repaired, barely repaired at all. And she underwent an MRI, MRA, and there was this thing sitting here. You could see it here. And some people in my section were looking at it. I wasn't on cardiac. And they were thinking it was thrombus in the left atrial appendage, which is odd for the position. Also, the signal in this is not like thrombus. It's quite bright on the SSFP imaging. And then there was the delayed enhancement imaging. And you can see there's this lesion here with intense peripheral delayed enhancement and central quite low signal, consistent with either fluid or thrombus. And again, you know, they were thinking, oh, it's going to be left atrial. And I'm like, geez, guys, that kind of looks odd. Initially, I was going to think it was going to be a paraganglioma, given the SSFP characteristics, but this changed my story. There's a lot of fibrosis around it. And then you could see from, you know, this is just showing her PDA on, or her coarctation on the 4D flow. And I think she had an old study, and I think people were just kind of focused on this coarc, because what you notice on the MRA images is that, if I could scroll through this, that there's this weird outpouching right here. And that's really all that you see on this. You also see the valve is bicuspid. This woman was treated in India with some unknown surgery, But then here's actually a MRA from about 5 years before. And again, people very kind of focused on the coarc. And you can actually see here, even on the new study, that there is, in fact, this very interesting outpouching here that does not belong, kind of at the level of the, somewhere between the annulus and the left sinus. Again, there's the bicuspid valve. And then the other interesting thing, if I go to this study, back to this study very quickly, is that she also had, so here's the delayed enhancement here, but then there's this infarct here. So I was looking, I was like, that's not a left atrial thrombus. You know, that's a big pseudoaneurysm. I would get a CT just to assess that, and also assess the coronaries, because the thing was quite big. So here you can see, in fact, there's this quite large pseudoaneurysm. So she must have had some sort of, you know, a lot of these patients, they have bicuspid valve. They also have issues with some degree of stenosis. So they must have done, presumably in India, where she had this surgery done, some sort of attempted balloon valvuloplasty, or at least that's what I would assume, that led to a rupture here. And somehow this rupture just walled itself off. I think there's another delayed phase, which is a pain in the butt to get to on this. Anyways, here's a delayed phase if I can load it somehow. Let's see. Yeah, and you can see this thing continues to fill up. So this is still filling in. So a lot of the dark that, you know, looked like thrombus in the middle on the MRI was in fact just very slow moving static blood. So this was a large pseudoaneurysm. And the interesting thing, presumably, we're not 100% sure, but that little infarct was likely due to the, let me see if I can go back to the original. If you could see here, there's a ramus that is basically kind of knocked out at its origin by the pressure effect. So we're not entirely sure if there was an embolic process into the LAD itself that led to some sort of little embolic infarct, or if this is chronic occlusion of the ramus leading to that little focus of infarct, which you can see right here, which is kind of where the ramus is heading towards. So anyways, interesting case. And then this is a really weird case. And let me see if I can get these ordered correctly. So this is a woman who underwent bilateral lung transplant. I don't have any notes on it except she underwent bilateral lung transplant for LAM in 2001. And I think what you could see better, this is a CT from 2009. And I think what you could see here is that she's started to develop these little cysts. And LAM is one of the diseases that can occur after transplant. So she's developed these little cysts throughout the right lung, which had been slowly developing for years. And then, let's see, and then she starts developing this weird process relatively. So that was 2009. This is like 18 months later, starts developing this strange upper lobe nodular nodules, could potentially be described as peribronchiolar or perilymphatic. You know, some of these are definitely peribronchovascular, some peripheral nodules. There's some fibrosis, the airways are pulled apart in some areas. And this process worsens, and she undergoes a right lung transplant. So the process worsens here, and she undergoes a right lung transplant, and all they read it as is recurrent LAM in the right lung and some fibrosis. That's all they say. Not very interesting in terms. So here she is so now she has that recurrent, so she does have recurrent LAM, that's path proven. But then she's developing this scarring with perilymphatic nodularity, at least in my mind, looks pretty perilymphatic, in the left upper lobe. Clear findings of obliter bronchiolitis based on expiratory imaging, which I did not include, in the left upper lobe. And here you can see the right transplant lung, which is retransplant, looks really good, but she has this progressive scarring. She's got a little loculated hydropneumothorax, and she's got obliter bronchiolitis in the left lower lobe. So my question is to you guys, what do you think is actually going on in the left upper lobe, and what was presumably the same process happening in the right upper lobe before transplant, because all the path report says recurrent lamb and fibrosis. She has clear, they said specifically there's no evidence of rejection, which is odd. There's, on the left, this is now 17 years after transplant. This is the initial transplant. We have obliter bronchiolitis in the left lower lobe and lingula. Do you think this could be, I was talking about the clinician, he was wondering if it could be, pleural parenchymal fibroelastosis in the left upper lobe, although I have not seen it associated with this kind of, in some areas, this kind of perilymphatic sort of nodularity. So what do you guys?
That's kind of what I was thinking, Seth, as a possibility. Did they do an elastin stain on the explant of the other one? Because it can be missed if they don't think about it.
Yeah, no, they did. I mean, they literally just, they didn't. And unfortunately, I don't know how long they keep their tissue for, but, the redo transplant was, in 2011. So it's 7 years ago. I doubt they probably, I can ask you if they still have it.
They probably have a tissue block, though.
Yeah, because it would be interesting to know what this process is.
Right.
This process here that progressed into that more confluent upper lobe fibrosis / pleural thickening. Anyways, when I first looked at it, I thought when I first looked at her most recent study, I thought she was going to be just a recurrent sarcoid. I was thinking, oh, this is a patient who got transplanted for sarcoid and it has recurrent sarcoid in the left lung, but in fact it's not. But so two interesting things: recurrent lamb, which is relatively uncommon, and then this thing, whatever in the left, could be both obliter bronchiolitis and pleural parenchymal fibroelastosis as sequelae of chronic rejection. But again, I don't know. I can ask the pathologist to see if they still have tissue blocks. Yeah. And this is the case.
I agree. It looks like restrictive allograft syndrome. I mean, the peribronchovascular stuff's a little odd, but the rest of it. Yeah,
because I was going with like those nodules are weird. But you think it's restricted? Yeah. And is there a difference between restrictive allograft syndrome and pathologic, PPFE?
No, I think that's what it is in the setting of lung transplant. I think it's the same as PPFE from other causes histologically.
No, I get confused by the different terminology, and I'm not sure if
I think the terminology sucks because if somebody walks up to you and says, "Here's a patient with restrictive allograft syndrome," you have no idea what that's going to look like. But if you say that somebody has upper lung scarring, they would at least be able to get a picture in their mind. But that restrictive allograft syndrome is, just way indirect. It's like walking around the diagnosis. So it's from chronic rejection. It's an upper lobe scarring process. I would say that the findings that you had before the person got the second transplant in the right upper lobe just looks like lung scarring to me. And it doesn't look like PPFE in the setting of idiopathic PPFE. It's just a lung scarring. I don't think that PPFE is a very good description either. I think it's a lung scarring process, and I don't think histologically is that similar to PPFE in the idiopathic setting. So I think we should just call this lung scarring from chronic, presumably from chronic rejection.
Which would make sense, but this is the crazy thing. That's why I have to have her look at it again, because literally he's like, there's no acute rejection, there's mild bronchiolitis obliterans. I have real some issues with, there's things I see on her path reports that I'm like, that there should be more to the story than just that. So I'm going to have her look at this, because the other odd thing is, again, and I don't know the rapidity of which here, but her study,
Can somebody mute, because there's a lot of crosstalk here.
Yeah, the CT from 14 months before, looks minus the little recurrence of the cyst, looks completely normal. But whatever it is, it did happen in that time frame.
And the other thing is, there might have been a viral infection that led to this scarring too. There might have been an infection. Absolutely. We're seeing the residuum of that.
Absolutely, yeah. It could have been infection. That's the thing that we were postulating.
But if I showed you guys that CT scan with all that scarring up there,
this thing,
I didn't give you the context, clinical context. I don't think anybody would call that PPFE because it doesn't have that peripheral finger.
You're talking about this one or the most recent, the one in two? This one here?
The one
No,
you just, the
oh,
one
this, yeah.
with all the
Even this
scar.
one. Yeah, I agree. It was a little bit of a.
I think the older study he was showing, I agree, it looks weird with all that peribronchovascular stuff.
Yeah, I mean,
the more recent one,
sarcoid. I really.
Yeah. Oh, I totally agree, and I agree with David that nobody would call this PPFE. I think the more recent one though that you showed, it was more confluent in the upper lobe. And David, you're right. Yeah, the PPFE, like idiopathic PPFE and patients with chronic rejection, they both have elastin fibers, so some of the histology is the same, but I guess my understanding is like the vascular changes are different.
Right.
So there's some similarity, but yeah, and I think I agree, it doesn't, it's restrictive allograft syndrome is not a great term, but I think they just say it's restrictive just to differentiate it from the typical bronchiolitis obliterans syndrome that you get with chronic rejection.
I think we can do better with terminology.
Yeah, I
agreed.
I definitely agree with the terminology.
Because right there, I think if you looked on soft tissue windows, you'll see that there's some just soft tissue abutting the pleura, and the pleura is probably thickened there, like you see.
Yeah, there's definitely, and there's fluid as well, but there's a lot of this is presumably some degree of thickening, because there is this loculated kind of hydropneumothorax up there.
I mean, I think we're agreed on the core thing here, that this is a pattern of lung scarring that is related to chronic rejection.
Yes.
The other indications of chronic rejection are the constrictive bronchiolitis
which she has in the lower lobe, which is kind of neat. You know?
And I think the possibility, given how acutely this came up, if it came up over 14 months, that's a little atypical for the upper lung scarring from rejection. That's exactly some acute insult in there, such as infection.
And that's what I was talking with the pulmonologist about, and that's what he thought. He thought she got infected and then just kind of went downhill from there, and that's why they gave her another lung transplant on the right. And then the last case is just, I'll show you guys. I don't have an answer on this yet. What I thought had to be, it turns out they're not finding it yet. Here's a guy who came in off the street, homeless, psychotic man for 20 years, has not a normal chest x-ray beyond the pleural lesions or extraparenchymal lesions, can't tell if it looks pleural, and all this very interesting soft tissue sitting there. So he underwent I had them reformat the neck CT. So here is the neck CT with lots of interesting badness coming out onto the skin, extensive necrotic lymph adenopathy popping out onto the skin from the chest as well. I will show you, you can see here these very nicely filled. So here's some of the stuff that's not popping out onto the chest. Here's some of the stuff that is coming out and communicating with the skin. Here's some of the stuff from the neck. And I was convinced I had seen my first case of scrofula. I had not seen a case of scrofula before, but this homeless man that was from Mexico originally, that's been wandering the streets of San Diego for 20 years. But interestingly enough, they haven't cultured anything yet. They've done multiple biopsies. It just shows necrosis and abscess formation, and no one's able to find a bug yet. He's quantiferon positive, but his PCRs are all negative for TB, but they're not finding anything. No tumor, no nothing. So they're just not getting, whatever it is, they're just not getting good samples. They keep sending it to Path. I presume it could theoretically be some massive tumor and malignancy, but I still favor some sort of very bad granulomatous or even other infection. Any thoughts on this one?
No.
Let's do leprosy.
I mean, I can do some pretty 3D recons. You can see the hole in the neck. Isn't that pretty neat? And then
wow.
Go. But the guy's been here like 12 days and no one can figure out what this is.
And is there actually like pus in this, or is it? Yeah,
no, there's oozing material. Not much pus though. It's mostly just they can go in there and they can squeeze and they can get stuff out.
So it's not
But
some weird lymphatic malformation or something.
Well,
no sulfur granules a la actinomycosis.
you know, I don't even know what the ID is looking for yet. From my understanding, everything has been negative. The blood's been negative. Everything they biopsied's been negative. He does have he has a fever. He has an elevated white blood cell count, which isn't that high. It's like, 12 versus maybe 13. You can see this stuff is even crunching off that right IJ. But I'm still hoping for scrofula, but we'll see.
Okay, I mean, or an atypical, another mycobacterial infection.
Yeah, and I was thinking, right, I was saying some other fungus or other weird mycobacterium. But
I think we ought to keep actino in mind, though, for the.
I'll actually bring that up to them. He's being seen by ID and everybody, and again, he said he literally has 20 biopsy results, and they all just say abscess and necrosis, and that's it. And they're saying specifically can't find any species of any bug. But I'll keep you updated on that one. That's what I got, Jeff.
All right, thanks. Those are really interesting cases. All right, David or Howard?
I've got a couple.
All right, change it. Give you control.
So continuing the theme of lung transplantation, I want to show you guys this case of a person who had a single lung transplant in the setting of emphysema. So the native left lung is emphysematous, and the transplanted right lung has much better texture to it, actually has elastic tissue in it. And we do have this ill-defined nodule with a nice halo sign around it. So presumption on this thing would probably be first a fungal infection, an indolent aspergillus, or in this part of the world, sometimes cryptococcus would be considerations, nocardia, and PTLD would all be considerations. We did a study back in the 2000s trying to determine when somebody with a transplant, solid organ transplant, might be heart or liver or kidney or something like that, or lung, came up with a nodule. Could we tell radiographically what was the cause of the nodule? So I was pretty confident going into that study, but not very confident coming out, because it turned out it was fairly random what I thought, and I thought with great confidence. So I think I would have gone with fungal infection for this, but this turns out to be PTLD. So very nice halo sign, should be aspergillus. Doesn't always follow my rules. This was PTLD. So
do you know if it was like a malt lymphoma or any more detail about it? Because I showed a case, I think it was last week, of a multicentric malt lymphoma that had nodules with halos, and I have another case that looked like an adenocarcinoma that was biopsied that was malt lymphoma.
Right. Adenocarcinoma should be on our list too. So that's another thing to add. This was an EBV positive thing. I'll look up the path and see if they called it malt lymphoma, but it was EBV related. Okay, I will check that path for you. And then here's a guy who has a syndrome and had, he's got heart disease at a young age, and he had this former radiograph. So at this point, he's had a mitral valve replacement. He's also had an amplatz replaced here because there was a pseudoaneurysm associated with the mitral valve. I think there was some infection or something like that, and they filled the pocket by putting in this amplatzer device up here. So we've got this thing floating just above the mitral valve, and this is 2017. And then in 2018, this is more current imaging. The person had developed lung edema here, pleural effusions, and had signs of heart failure. And here's our mitral valve again, but now notice that the amplatzer now is overlapping the mitral valve. Previously, and here it is overlapping on the lateral view. I don't think I would have picked this up. Just to compare the previous one here, you can see that this is passive aggressive behavior from Osiris, because I've not updated it for a few years. So previously the mitral valve was down there, and the implanter was above. So this thing has actually loosened and flopped down, and is actually sort of sitting right in the middle of the mitral valve. So I think I can show you that on, let me try on coronal CT around this time. Here is the implanter sitting right on top of this mitral valve replacement, and maybe I can show it to you on the sagittal. Here they are combined together. So this person required reoperation. They redid the mitral valve. They removed this floppy implanter, which had folded down there, sort of embolized to that location. And they tried to repair the cavity. They oversewed it and things like that. So they had to do a lot of surgery. And this was a reoperation that was very long and messy and stuff like that. But I don't know whether you guys have seen an implanter loosen from this location where it was filling a pseudoaneurysm and then flopped down. I don't know if it was totally loose. I couldn't get it from the op report whether the thing was actually loose and just sitting in front of the valve, or whether it still had some attachment and it just sort of hinged down into this abnormal position. But it was the cause of his mitral valve dysfunction and his heart failure. Is this a familiar problem to you guys?
Oh, no. Once in 10 lifetimes, maybe.
Is Seth still with us?
That's crazy. I mean, I think it just goes to show understanding, how I always try to teach residents, understanding, not just say there's surgery from prior median sternotomy, but like actually recognizing what's there. And that's the only hope of seeing this, is if you notice that something isn't where it used to be.
Right. I didn't, the resident who was on call that night did not pick it up, and I definitely, I would not have picked this up, but one of our attendings, who's a cardiac guy, did pick it up, and the CT was, of course, definitive. So I hope he picked it up before the CT, but quite a case. Okay.
Yeah, that's really impressive.
Okay, so here's a fellow at Harborview, a Mexican patient with this mediastinal widening and fever and night sweats and weight loss symptoms going on over several weeks. Mexican origin. I don't think he spoke a lot of English. He does have this mediastinal widening and these fine nodules throughout the lungs. On CT, he's got a lot of low attenuation lymph adenopathy here, throughout here, and he also had back pain. He's got pericardial effusion, and he's got a ton of lung nodules, fine nodules going everywhere, and what looks like cavitary disease up here. So here's a few images from his MR study of his spine, and you can see that he's got this paraspinal psoas and psoas abscess down here encroaching on his spine, probably involving the bone with inflammation. This is post-GAD. So tons of infection here, low attenuation lymphadenopathy, upper lobe cavitary disease. Everybody was thinking TB, and it turns out this is coccidioidomycosis. This is Coxy. So we see Coxy look a lot like TB in terms of having lung disease, in this case even miliary disease, lung cavities, low attenuation lymphadenopathy, and it likes to disseminate and cause bone disease too, which we have in this case. So a lot of similarities between Coxy and TB. And it's thought that dark-skinned people, including Mexicans and particularly Filipinos, are particularly susceptible to Coxy. So in the Central Valley in California, there are big Filipino populations, and that's where valley fever is, and so they get particularly hard hit. So
that's a very strange combination. Unusual.
Yeah.
Oh, the other interesting thing is he had some swallowing difficulties. So let me show you. He had the swallowing study here because he had some dysphagia, and so he drank some barium. And in here there is an extravasation. There was, it turns out, a fistula between the esophagus and one of his necrotic lymph nodes, and that is filling now with contrast. So this organism likes to form fistulas, again, the way TB does. So this is esophageal scrofula. I'm just going to get Seth back in the game here.
That's impressive.
Okay.
So if that heals, is that something that would form a traction diverticulum like you see with old granulomatous infection?
Great speculation. Don't have a whole lot of cases to for that argument.
I mean, I just don't. Yeah, I've always wondered, how patients with granulomatous infection get these traction diverticulums they always talk about, that you occasionally see.
I don't think. I don't think that's something that you actually have to have a fistula. I think that you could get that from the inflammation, and then something shrinking that was something paraesophageal could exert some traction on it, but you have to actually have a connection to get that phenomenon.
But I like your esophageal scrofula there.
Did he? Did he have anything like conjunctivitis or like a weird skin rash that would suggest maybe this was Coxy before they got tissue?
I don't have his history in that detail, Jeff.
Okay. Because that's one of the things with valley fever they can get is conjunctivitis, and then a variety of rashes. Something like real bad, like erythema. Was it erythema toxicum? They can also get enodosum, but I think that one of the things that would make it a little the conjunctivitis is sort of pushes you more toward in the right geographic setting, thinking of Coxy over any other endemic infection or TB. But I was just curious.
So the thing about this is that he might have acquired this in Mexico, because the northern part of Mexico, the dry Sonora Desert part, has Coxy, of course, and it goes pretty far down. I think it even goes into Central America. But then a lot of the people who work as are farm workers in Washington State, east of the mountains here, that's an area that now is recognized as an endemic area for Coxy. It used to be that most of our cases were imported from Mexico or from the Central Valley in California. A lot of the farm workers in different seasons will work in different geographic locations. We had a case of a man with Coxy. He was a Mexican national, and he came down from Alaska, where he worked in salmon canneries during the summer. But the guy also worked in Washington State, picking cherries and picking apples, and in the Central Valley in California. So his migration in this farm work and salmon cannery work took him across, 4 states, and tremendous north-south. So just because you're in Seattle doesn't mean you've not been in other parts of the world that have Coxy, and now we have it in our state as well. Okay, those are the cases I wanted to show.
All right, thank you, David. All right, Howard, do you want to go?
All right. Well, here's a nice companion case, because there seems to be a certain theme here today. So let me show you a bedside radiograph, and then I'm going to show you frontal and lateral projections that were obtained a little bit later. So I came across this case in the context of reading a CTPA that was done for chest pain, but for pulmonary embolism. And this will be illustrative of 2 things. One is what I call a hidden lesion. So stare at that for a moment. Of course, it's a bedside radiograph, and I'm certain you won't see anything. And here is one that was done after the CT, which I'll show you in a moment. And I will say that you can stare at this as much as you like, and you won't see anything. So if you had to guess where you might hide something that's more than small, it's going to be in the posterior portion of a lower lobe, somewhere down here. And indeed, that is the case. So let me bring up the CT, which does not show pulmonary embolism, but shows this bigger than small lesion in the posterior basal segment. And that's what it looks like. you can see that there are some vessels that are undisturbed passing through the periphery of it. And if I mag it up a little bit and scroll around it, one hint as to why this is not a cancer is that there are a couple of airways that have slightly thickened walls, albeit just slightly. And sorry about that. And some of the airways adjacent to it have material in their lumens. So that undoubtedly accounts for his symptoms, but not pulmonary embolism. And then based on this information that I'm going to show you, the diagnosis of Coxy was made. So this patient did come here from California. You can see that IgG and IgM are positive. He does have an eosinophilia. So a diagnosis of Coxy was made for this, and he was started on treatment for Coxy.
Howard, what's going on with his pericardium? Does he?
Oh,
looks like he has a small effusion.
He does have.
Was it involved too? Because looking here shows that he had more anterior chest.
I don't know. So there is some pericardial fluid, and there is some lymph node enlargement that's relatively modest. So I don't know. Yeah, that's actually an interesting speculation. Does he actually have a pericarditis as well? I don't know the answer.
Well, this is why PE studies are terrible for looking at the pleural and or the pericardium, because you just don't give it time to enhance.
Yeah, so that's a good question. For some of his chest pain, well, he's got that lesion down there, but does he have a pericarditis? And presumably some of these lymph nodes, particularly these regional nodes, are presumably reactive lymph adenopathy, presumably. So that was kind of interesting. This one I'm going to show, we've seen this one before, but it's such a nice example of the, and I sent this one to you guys earlier, of the so-called interrupted bolus artifact. So we have a force scanner. So these scans for pulmonary embolism are completed in less than a second. And what's dramatic about this is that you can literally see the bolus of non-opacified blood, a discrete bolus of it in the pulmonary arteries. And obviously contrast medium has passed through the lungs, but there's an additional bolus coming from the SVC behind it, kind of pushing it along. So here and there, the gray pulmonary arteries represent the bolus of non-opacified blood making its way through the pulmonary arteries and rendering them just plain old gray. And there's contrast medium behind it with a fairly discrete interface between the relatively opacified blood and the non-opacified blood. That was earlier in the day. It was repeated a bit later, and I don't know why it happened, because our techs are instructed to make sure the patient does not take a deep breath in, but this is just the repeat exam done later in the day, which was normal, like that. So a really nice example of the interrupted bolus. Here is a really nice example. I'll just make this my last one. We've shown this before, but this is such a nice example of the so-called septal lakes in interstitial edema that I want to show it to you. So let me just bring this in here and bring it in twice maybe, and I'll show that to you. I'll make this one a coronal, and to make it really nice, I'm going to make both of them a MIP, or at least a thin MIP, like that, and then I will scroll through it. So a really nice example of the septal lake. So this florid edema, and then in locations like this, the lakes, the nodules, the lakes here are really nice examples of it right here and right there, for example, are really rather conspicuous. Of course, there's also foci of alveolar edema, but again, I'll just scroll through this one, say, and you'll see tremendous thickening of interlobular septa with lots of nodules of septal edema, making nodules there. So I always tell people, you don't have to invoke a different diagnosis for the nodules. They are septal lakes of interstitial edema. So a very nice example of that. Alrighty, Jeff.
Okay, thank you. Okay, I have just a few this week. Hopefully my Osiris won't give angry warnings. So this is a 54-year-old patient that was transferred to our hospital. And this was the outside chest radiograph. And this is a good case for trainees getting ready to take call, or also people who work in the middle of the night, or even experienced radiologists that got to always pay attention to detail. So this was for line placement, and this was correctly reported on the outside as an unusual location for the central venous catheter. You can see that first of all, it's supposed to be a subclavian approach. It courses over the clavicle, which is abnormal. And then it also courses straight down, overlying the aortic arch, and then what would be maybe the descending aorta. And the outside radiologist correctly went back and ruled out any anomalous anatomy, such as a left SVC, which should be lateral to the aorta anyway, and said this, could be an arterial line. But whatever reason, we don't exactly know all the details. And it was communicated and everything, but it was not handled appropriately, and the patient then subsequently got their CT angio of the chest. And this is just something you don't see every day, is an iotothorax. So nice, a contrast pleurogram if we want to create a new study.
Wow.
Yeah, and so this was not actually arterial at all, but it had gone into the pleural space and just happened to be located right behind the aorta. I showed you one that looked like it was in the SVC that was in the pleural space on the other side that had other medications and stuff put in, because on the chest radiograph it actually looks lined up. But even though we report these, we hopefully call when it's this concerning. Somehow at some other institution the communication broke down and this was injected. So this is the full 100 or 150 cc's of contrast. Unfortunately, I don't have a radiograph to show this, but it almost makes you wonder, could you do a contrast pleurogram with a dilute contrast to look for pleural tumor?
But that's like 2 liters of fluid, though.
It's a lot.
Were they giving him other fluid too? Because I guess historically this was originally called a glucothorax.
Yeah, this is I don't know. I agree with you. Well, all I know is they put in a drain at the outside institution and sent the patient to us to deal with this issue and some other things going on. But just one of those things you don't see every day, but always it's just a nice example of a malpositioned line or line misadventure. All right, going along our fungal theme, this is something I like to show a lot of, but I think it's good to see it because we always have to think about it. So this is a 25-year-old African-American male who lives originally in a large city and then moved locally, never been outdoors, always an urban environment, otherwise previously well, and presented with a cough and fever back in August and had this radiograph that shows consolidation and some nodules in the right lung. And this was reported as a community-acquired, as an infection, and patient received standard of care antibiotics. Presented about 2.5 weeks later, 3 weeks later, with worsening symptoms. I should put these up side by side so you can see that there has been a progression. The mass-like area is larger, and there's more nodules on the periphery of this. We don't see any lymph adenopathy on the radiograph. We don't see pleural effusion. And then subsequently was given another round of antibiotics and presented, and I'll just take away this one. You can see continuing to get worse. So a rapidly growing mass in the right lung. So kind of moving over the course of 5 weeks. So moving a little fast for mycobacterial disease. Does have pleural effusion at this point. So they did a CT scan. I'm not sure how much that really added because it just kind of confirms the abnormality. But there are all these nodules, and we can see some are central lobular, airway centric, tree and bud, and then this more confluent consolidation around the right upper lobe, and then some extension into the right lower lobe, and a small layering of fusion. There's no lymphadenopathy and nothing else. So they bronchhed the patient and did the usual stuff. And on the pneumocystis stain, they saw budding yeast, highly suggestive of blastomyces dermatitidis. Final culture isn't back, but with the morphology and everything else pointing to it, this is a case of blastomycosis, and the patient's currently on treatment. It's just unusual that he saw infectious diseases after a very detailed history, exposure. He has no risk factors for it. I mean, always living in an urban environment. We had some major flooding here a few weeks ago, but he got sick before that. So we've had a lot of standing water or elevated lake levels and still high rivers and flooding areas. So no good explanation. So there was a series out of Milwaukee, years ago, of people with blasto, and a fair number of them lived in the city. So it can even live in urban wet environments, little lawns, gardens, and things like that. So
does he have a dog?
I'm sorry?
Does he have a dog?
No pets.
Really?
Yeah, that's a good point.
No pet fevers or anything.
Yeah, and you don't get it. Yeah, the dog is a risk factor in that if the dog gets blasto, it means you've been exposed to it. Most likely, it's non-contagious because the yeast is not the yeast form in the human body is not contagious.
But I just wonder if the dogs would track it in, if they're
right.
wet feet, track it in.
They'd have to bring in a pretty good inoculum. I don't know that. Usually they're digging around, running around in areas that with high concentrations. It's extremely difficult to isolate in the environment. That's the problem. So other than heat maps of cases based on epidemiology, actually going out and finding areas in the environment is near impossible. But so the things that make us think about blasto, besides the non-resolving infection, is sort of the mass-like appearance to it. There's often airway-centered nodules in the vicinity, and pleural effusion is an uncommon finding, and when it's present, it's usually pretty small, as in this case. If you go back to the radiograph, it wasn't particularly that large. And usually with a bacterial pneumonia that's been brewing for 4 or 5 weeks, you typically start seeing some serious pleural effusion. And then unlike the other endemic fungi, lymph adenopathy is very uncommon. We do see it sometimes, but he's got some mild lymph node enlargement, but it's not the stuff you see with histo that's 3 times the size of normal.
Very interesting.
All right. This is kind of a cool case because I have a lot of serial imaging. So this is a patient with a head and neck squamous cell cancer who has metastases, is on a taxane, paclitaxel, and received some radiation to the spine last fall, sort of around, I think, November, December, for a metastasis for palliation. And over serial radiographs developed this finding. So this is January, you can see there's this paraspinal consolidation down in that right lower lobe, and that's about the only finding at that point. Maybe a little touch of it here in the left lower lobe, but it looks like early radiation-induced injury. Now, 2 minutes later, the patient comes back for surveillance, and we see sort of the typical developing radiation fibrosis, but you'll notice it's starting to come out a little bit more peripheral and more nodular. But early on, that's, I think, not an unexpected finding. It's primarily confined to the area of the spine. So that was March. Now we jump ahead about 6 weeks. So patient's back for more surveillance, and you can see it's becoming more exuberant, which we typically see with radiation. But it's really taking on an organizing pneumonia-like appearance. It's crescent-like. You can see it perilobular distribution. And then started to get a few areas in the right upper lobe outside the treatment field. Now, of course, head and neck patients will aspirate. They get infections. They get mets. So that's one possibility. It's a little fuzzy for a squame met, but not impossible. But at that point, the patient was presumably just doing okay elsewhere. And then this is 3 months, about 2.5 months later, where you really get this peribronchial area of ground glass consolidation. Looks very much inflammatory around the airways. You might think aspiration. And then you can see this radiation fibrosis is continuing, or injury in that area. The organization is moving more laterally. So now we're getting really outside the treatment area because usually it's a PA, maybe some angled beam to avoid the esophagus, but it's not a typical SBRT type pattern. And it's got these nice sort of atoll looking picture and some findings more peripheral. And it just continues along. Here's another one. This was the most recent one. And you can see at this point, it starts to melt away as it moves more laterally, but the consolidation melts away. But the stuff in the right upper lobe also seems to melt away. And it seems like, to me, reading a little bit, I think what was going on is this was a mixed drug toxicity with some amplification in this area because of radiation. So there was a radiation injury, and when you mix chemotherapy and radiation, it's more common to see local toxicity. So I think it sort of primed the lung here, and that's why we saw a little bit of radiation. But because there was also a taxane on board, which can cause drug toxicity in the lungs, it sort of primed the rest of the lungs so that this inflammatory process continued on and actually spread it into outside the treatment area. So with the taxane stopped, a lot of this got better. So I think it's sort of a mixed radiation drug toxicity, just kind of a really neat pattern to watch it move peripherally. It'd be kind of neat to somehow put this together into like a movie and watch the organization move.
Cool.
Yeah.
Very, very interesting.
So,
Gosh.
all right. Well, that's it. And it's 3 o'clock here. So thanks, everybody. And Travis and I will be at the ACR next week, so we won't be available. So Howard, you and David and Seth can hold down the fort. And if people are busy, we'll wait and meet back again in another week.
Thanks, everyone. Nice
All right,
cases.
take care.
Thank you.
Bye-bye.
You guys have a good week.
You too.
Everyone.